Nancy Joyner is a nationally recognized consultant, speaker, educator, and author. She's a self-employed palliative care clinical nurse specialist. Nancy has extensive experience in serious illness, frailty, and end of life in over 40 years of nursing, with 14 years of advanced practice nurse in palliative care across the lifespan. She's a subject matter expert for palliative care for UND's Center for Rural Health community-based palliative care project. Nancy's an approved educator for the Hospice and Palliative Nurses Association and a certified First Steps ACP facilitator. She is nationally trained Pulse trainer and is currently president of Honoring Choices North Dakota and North Dakota's Pulse program coordinator. She has a BA in pre-medicine from Bemidji State and her BSN and MS in nursing from the university.
For over 15 years and absolutely loving it. And our topic today is really rural palliative care. We've done some presentations already through Project TeleECHO about palliative care in general, but we're going to bring it specifically to where we are, to meet people where. I have three objectives I'm hoping that we really accomplish, is really to distinguish palliative care and its impact on why it's important in rural communities and why we have some of the barriers that we face. But we're going to look at definitely determining some strengths and opportunities for advancing rural palliative care. We have multiple definitions of palliative care. This is the newest one from the International Association of Hospice and Palliative Care. It's a consensus-based definition. We formerly had the World Health Organization's definition, but I really like this one. Palliative care is an active, holistic care of individuals across all ages with serious health-related suffering due to severe illness, and especially of those near the end of life. It aims to improve the quality of life for patients, families, and their caregivers. Now, the other definition that we often will miss is serious illness. This is the definition that came from the 4th edition of our National Consensus Guidelines for Palliative Care. It's a health condition that carries a high risk of mortality, so we know the disease perspective of it, and either negatively impacts a person's daily function or quality of life, or excessively strains their caregiver. And I bet everybody here today has not seen this before, because it's such an important component that we need to really look at when we talk about serious illness. It's not just about the disease, it's how it's impacting the person and the people taking care of them. So for rural palliative care, we have principles of the care, our domains of the care we'll be talking about, but overall, we want to get back to the compelling case of it, that the goal is to relieve pain and suffering, which means different things to so many different people, and that we are able to ensure the best quality of care that we can possibly provide. We're still going to do those curative treatments, but care is where we really want to focus on. So we address the benefits and burdens of them, the changing goals of those care, and when to begin or discontinue a treatment. Is it time-limited trial, or what are those things that are there? So that the care for that whole person, wherever they are, they shouldn't just be in the hospital or in other areas. We need to go to them. So the support for the patient's family and others as well as requiring that idea of the whole team. It's not just a one-person component. They're actually the 8 domains of palliative care. And over the next series of these Project Echoes we're going to do is we're going to be discussing how important they are and how to include them in the dynamics. So the structure, the physical, the psychosocial part of it, the psychiatric, the spiritual, religious, which we don't talk about all that much, and cultural, we definitely have those dynamics that are there. Many people associate us right away with the domain number 7 in hospice, which is care of the patient nearing the end of life. When does end of life begin? We know from the minute we're born, but where are we nearing that end of life? And then definitely ethical and legal aspects that we often will do. This creates a true blueprint for a comprehensive foundation for the standard of care of what we want for people receiving any palliative care. But we're going to, like I said, over the course of these Project Echoes on the rural dynamics and how to make it work for there. This is why we really are talking about it. And hospice came around, this is Dame Cicely Saunders, if you don't recognize her, and we recognized that back in the 1960s. By 1974 is when it came to the United States, and said, yeah, we need more of that. So the concept of palliative care was definitely part of what was going on, but not to the degree of what we were hoping it would be. So the first actual hospice was established, but it wasn't until the 1990s that we saw it as a differentiation. And then in the mid-1990s is when people finally were thinking that, you know, we needed that Medicare benefit, the 6-month, et cetera. And that's where it became segregated instead of a continuum of flow, you know, that whole bridge approach of where it is. So we know that the newer models now, and since the 2000s, is that we have hospitals, more than 63% of hospitals have some component of palliative care in it. Over 85% of those with beds of over 300 have some perspective of palliative care. When I first started doing it, it was less than 25% back in the early 2000s. So we've come a long way with that. So now we're getting ambulatory clinics, we have interdisciplinary home care, we have managed care teams, hospital-based, and the newest one now is rural community-based palliative care. So we're very, very excited to be able to have this and move forward with it from there. So here's our report card. This was done, they've done it twice now. So this was the 2021, showing where are we and what are going to this. So according to the newest reports, you know, we see the growth of overall hospital palliative care teams, but we haven't done as much with getting it out into the rural settings. And we want to get on the map. And that's, many of you that have worked with me know, I keep saying, put that on your agenda, getting on the map. And so we know that 67% were there, and now we have more and more. The grade is based on those hospitals that have 80% of the hospitals report some kind of palliative care team. And look at us, we're doing great here in North Dakota, Montana. Minnesota still has a little bit to go, but we're still way up there, and we're so happy with that, so that we're moving forward in the direction that we want to be able to do. We do have some problems though. The focus of palliative care, like I said, has been inpatient. Palliative care, either units or academic and tertiary centers, where they're bringing palliative care to the inpatient perspective where that person is. We now say though, why don't we offer palliative care upstream, influencing decision-making results in fewer patients entering the hospital, especially if they're nearing the end of life. But if you look at that serious illness definition, we have much more people to take care of. And everybody on here really understands this, that we are different here in a rural setting. And we have, you know, so many of our counties are not only rural, but we have frontiers, less than 6 people per square mile, which we'll talk about in a minute. But I love the upper left-hand one. I really like, I think that looks almost like a dove or an angel up there in that cloud. I think that's just such a neat picture, but I'm sure all of you can relate to this. I'm going to throw out one case study, and then we're going to open it up for others later in our discussion today. So here's a case study, and again, no HIPAA type things going on. So really understand this. So we have Helen Johnson. She's 83 years old. She's married, Norwegian Lutheran. I'm sure many of you already are. Yeah, we have people like this. So she's admitted to a local critical access hospital. She's got recurrent ovarian cancer. She's got ascites. She's got dyspnea. She's got medical issues going on. So now she gets transferred to the academic center 90 miles away to help to take care of those symptoms, to do more workup, to do more research, to find out what else is going on. She's seen by specialists in gynecology and oncology. They recommend chemotherapy. Now, however, we have Helen that has limited English skills and accepts treatment because if a doctor offers it to her, why wouldn't she take it? They didn't go over risk, benefits, burdens, and expected outcomes in Helen's case, right? And I'm sure, again, I'm probably preaching to the choir that you see this happening all the time. But the family is unable to visit. So it's almost like in our COVID world right now where people can't get to where they are. Sadly, Helen dies alone in the hospital from a neutropenic fever and sepsis. How sad is that? And how could we have made this different? How could we have prevented this series of events, given more options, been able to do that. Another thing that comes up is, what is the criteria for being a critical access hospital? Again, preaching to the choir, but I really wanted to make sure that we're on the same page about this. You know, the rurality of it, the 35 miles, that secondary roads, more than 50 miles from others, fewer number of beds that are there, up to 25. Do you have, you know, long-term care or acute care in there, a swing bed type aspect that is there? And then you must restrict the length of stay, you know, for how long that they can be in there. Well, and do you have specialties? You know, what do you do about 24-hour emergency, and where does that person go from there? So it must be owned either publicly or from a nonprofit perspective. And if they don't meet it, they have to have other state criteria to be critical access hospitals. Now you add rurality to it. So this is showing metro versus micro. And I love that idea of micro. So the metro is all the green colored, the micro is, you know, the smaller areas, but the not metro or micro, which is less than 10,000 people. Look at our state, look at North Dakota, look at upper Minnesota area, look at Montana. I mean, we have a lot of areas that we have to look at. We have smaller areas for income, we have poverty, we have all these other needs that are there. Then they took a look at the hospital-based palliative care. So the rural ones are the teal colored or whatever, the blue type color that is there. You know, that they're scattered compared to the number of the grayer, the darker color that are there. So is it rural or not? You know, so yes, it's there versus the grayer, nowhere, anywhere. So again, look at, we have a lot. I have my role cut out for me. I have a lot to be taken care of because there are people everywhere that we take care of. This has been this is from the Center to Advance Palliative Care, CAPSI. They just provided this map for me. And I'm looking at our western side of the state. They are expanding out there with ideas of palliative care programs. And so we're so excited to do that. We have the rest of the state to reach out and say, how do we make this work? What are the things that we need to do? We know that there's so many challenges that are ahead that we're facing right now. Our service gaps is the biggest one, you know, less access to any kind of palliative care services, you know, that people think that they have to be experts, but look at those different domains. I'm sure that we talked about that, and we need to really emphasize with how can we make this happen? Reach out to those people that can fill in those gaps. And just we'll talk about some of the innovative approaches we can do. Cha-ching, of course, the cost of services and related to the population. You know, what are our priorities and where do we set them at every given time? So the greater need is disproportionately ill. We have disabled, we have poor, we have older, we have a range of chronic conditions that are going on out there that we have to do that. How do we sustain it? You know, how do we make that? And how do we disseminate those advances in education that are there? Geographic isolation alone, you know, people have to drive, you know, 50, 100, 120 miles to get to the closest dialysis unit. You know, so, you know, some of the geographic things, you know, to be able to provide palliative care along with disease-focused type care that's there. And the whole idea of the nature of our rural relationships. Is there a boundary issue that's there, or what are some of the other ones that are needed? But I know a big one is the competencies required for rural palliative care. How do we get that out there? So I'm going to ask that question to see where we are. So Julie, can you pull up the next poll, please? Since all of you are doing it, you can answer this one. We should have put an other in there, shouldn't we? And then we could have more discussion, but we will. We'll leave it for more discussion. So keep this one in mind. You only get to choose one. I know, ding, ding, ding. Everybody wants this. All of them, all of them.
Give it just a few more seconds here. We're almost to 100% on our answers. So
Nobody has billing, that's wonderful, but sustaining it and competencies. And these are things that we're going to be taking on over the next, definitely, we'll be talking some of it with some of our project echoes, but we're going to, the Center for Rural Health is going to expand what we've done in their project and reaching out to other sites to be able to do this in the future. So keep this in your mind that we are not done with this yet. We have those things. Then adding to our, just missed it here, there we go. Adding to these challenges are coming from different areas. And this came directly from Dr. Diane Meyer. She was former director. She just recently has changed her position with this, but she gave me permission to use this one. We know that we have patient barriers themselves, so we should start there. You know, people want to stay at home. They don't want to go to other places. So community needs to come step up and do that care for them. Definitely transportation issues, the long distance for palliative care centers, for visitors, for everybody that's there. And then the concerns that they're going to lose touch with the providers, you know, that they feel abandoned, that they don't have the people that were originally involved with their care now providing it for them. And then for providers, again, we don't always have the experts. Only 22% of hospitals with less than 50 beds have any kind of palliative care involved with it. And that exposure to palliative care patients in rural practices, you know, they're not having as many people that are having aspects that they're not having those deaths, but they have all the other serious illness. So there's more that we need to take care of. So that education isn't there. How do we have that availability of education? And so these are things that we really want to work on. And then system barriers, you know, for practice, communication. Oh my goodness, just the whole idea of hospice versus palliative care. And can we offer that? And how is it paid for? And how do we bill for it? And what about advanced care planning, et cetera? And how do we do it from an academic to a rural community setting? And how do we make that work? Technology, for sure. This year of COVID, where we've learned so much about telehealth and that we don't have enough Wi-Fi out for everybody. And how do we communicate with people? And the whole idea of technology and techniques. Can we run a pain pump out there? What do we do if we run out of electricity? Do we have generators, et cetera? Especially if somebody has complex problems. And we know that the best practices or models is still not really being understood. There are not enough studies to really know where we're going with this. We are now looking at, over the last few years, and has been published just recently, some incentives to keep people in local communities with some sustainability, with utilizing critical access hospitals and some of the other aspects of that. Again, I mentioned earlier the whole misunderstanding. This sheet that you see is on, if you Google North Dakota Rural Palliative Care, this is our sheet that we use to try to help people understand it and where they are across the whole perspective there. So that palliative care and hospice have different meanings for different people. We have multiple stakeholders, you know, from, is it Blue Cross Blue Shield in the payers? Are we looking at other things with that can lead to the next one with financial constraints? And definitely different settings for different disciplines. Are we utilizing more of the advanced practice like a nurse practitioner or PA, or do we want to utilize local physicians or traveling physicians that come along with some of the providers? But it even is more important to now include community and some of the other aspects of it from different disciplines, social work, chaplains, nursing, even EMS, and we'll talk about that as well. And that there's not the priority of experience with working with these components of palliative care. We're so been disease focused, now we're doing a holistic component of it. So we have yet another aspect that we have to do. And what about participating organizations? Are there some in our community that we can use as resources? Can we reach out to some that we're not in a competitive or that we're not having any of those kind of issues, conflict of interest, that we can work together? So we get down to what's one more hat to wear. You know, we have all of these different, every day there's something new that we have to be really looking at. And so we have to really determine which way are we going? What's our priority at any given time? And palliative care should be one of them, you know, on the burner somewhere. And then there's COVID. You know, we have this whole new perspective of what's going on. And oh my gosh, you know, we have this huge pandemic, you know, that we have yet another hat for our collection, you know, that we need to really, how are we going to add yet another dynamic of incorporating palliative care into the care of the people that we're, because P right now is for the pandemic. You know, some people in our communities have taken what they call a palliative pause because critical access hospitals and other service providers have to be all hands on deck, you know, with everything from testing to vaccinations to any other components of what's going on with that. So the other P now is from pandemic. We want to bring back the idea of palliative and what are the aspects that we want to do. So we have to move from 2020, the vision of all of this, to moving forward with what are we going to do. You know, we know that economics is really, you know, with loss of employment, insurance, you know, some places have had to downsize, you know, losing some of their facility people, et cetera. But the vulnerable populations, you know, getting them into the clinic or telehealth options have been wonderful. And I usually, when I'm working with people, I try to say, is there another person we can get involved, just in case there's a technical component, a visual component, an auditory component. So any kind of remote monitoring that we can do there. And then definitely the components of aging in place, you know, with long-term care, you know, with how are those people still connected, the connectedness that we need to be there. So our home-based care program development in conjunction with like Medicaid, et cetera, that we want to be able to expand and make it better. But don't forget the younger population. They're also facing their own and their own families' mortality kind of components of it. So how do we bring this forward and moving to make it sure that it's a stronger component? So we want to look at some strengths and opportunities, you know, with what are some of the things that are there? Where definitely a person to reach out to for that. We're doing much more training in primary healthcare professionals for implementation and reaching out to them. The EMS, there are communities that are using them as the person that can go out and do kind of a quick, we use like the Edmonton Symptom Assessment Scale, you know, bring back that education versus having to bring somebody in, trying to be that connection there. Definitely with community representatives. So even from a volunteer perspective, we can be looking at it from there. And definitely community academic partnerships, like I applaud having Project ECHO, that we're able to reach out and be able to have times for talking about cases, which we're going to do today, and leave it open, like, you know, in so many different perspectives, some of the Q&A components that are there, that it's community united, that we're putting these puzzle pieces together and making sure that it works for everybody. So again, I mentioned Project ECHO. I'm so excited for the Center for Rural Health. We had all this training done from Stratus Health. Now we have that information that we can disseminate it even more. One of our biggest advocates is from the Center to Advance Palliative Care. It's a national. If you haven't gotten involved with them, I highly recommend that you do reach out. They have what they call the Tipping Point Challenge. They offer education to everybody once you get involved with the Center to Advance Palliative Care. And there are people that have done this and have made big progress with their palliative care programs with wherever they are. Definitely telehealth. You know, we have all these new means for doing that. And then going back to the community lay navigators, how do we incorporate that to make sure that somebody is strong enough to be able to move forward from that perspective? So again, you know, I want to make sure that people understand it isn't just the people that are specialized in palliative care. We're bringing it to everybody at any level that it's there. So just from the slide perspective, and I've got lots more to show, but I want to have some time for dialogue and just some other kind of case study type perspectives on it. We know that palliative care is appropriate at any age, any stage in serious illness, and we'll go back to that definition of serious illness. So it can be provided along with curative treatment by all of us. So people may need palliative care no matter where they are, in the hospital, the community, nursing facilities, and rural homes. So we need to go to where those people are, not bring the people to us. And I just found this article last week called The Integration of Palliative Care into All Serious Illness Care as a Basic Human Right. Access to palliative care is a human right. Our inability to deliver it even in a rural setting with COVID or other serious illnesses is a human right violation. Each of us is a stakeholder. Health system and clinicians are charged with meeting the holistic needs of patients and family caregivers in the face of serious illness. Education, payment, and health equity reforms are needed now to hold all clinicians, every one of us is a clinician, I didn't say provider, clinicians accountable for those we.
Okay, so the case is a female that's in her upper 70s, living independently at home, having some falls, diabetic, and some alcohol consumption as well, loneliness, stubborn, but a really cool lady. Okay, and what she really kind of doesn't want is, she knows she's neuropathy. She knows that life isn't going to be real easy, but she hates taking all these pills, and she doesn't like coming into the doctor. Willing to do some home health, but doesn't like a ton of visits, you know, because they're real cycled and very, you know, scheduled by regulations. And so had an admission again recently, and the provider texted me, we're small, rural, very busy though, clinic. And, you know, palliative care. Well, what do you mean by palliative care? I said, well, she just wants to make some decisions on her own. Would like to kind of back off on some things that we're treating her for. Well, it's hospice. I said, well, no, not really. I mean, you know, let's contact hospice, because Hospice of Red River Valley does have some sort of palliative care. That's our resource now.
Okay.
Here. And, you know, well, I said, you know, I can make the referral for you if you want, or here's the phone number. You know, and then the physician is like, she has a nurse that is big hospital. So I'm sure we'll figure this out, because big hospital knows what palliative care is. Well, we do palliative care, but it's in a different way. Mm-hmm. But there is this misunderstanding. You know what I'm saying?
Exactly.
It does not have to happen in the hospital.
Correct.
As a care manager and as a care coordinator, you're working to keep people in their homes as long as you possibly can. And that's new for us, right?
Correct.
For over the last 5 years. I connect and collaborate with so many different agencies like you guys. You have so much great education, but our providers in small rural care are still busy taking care of the ER and the patients and their patient clients, and that's their people. So at times it's hard for them to adjust to these new programs. And as nurses, it would be great if the state of North Dakota would figure out palliative care nursing. You know, how do we do that?
Right. We are actually working from the state of North Dakota on getting we used to call it a task force, but we're looking at developing a palliative care network, so that we can have a way that the primary care that are not familiar with it can get better understanding and awareness of it, but it's not taking over, it's not replacing them. It actually becomes a win-win-win, because it takes some of that burden, because they're not going to be able to go do a home visit. They're not going to be able to do some of those things. So that awareness and education, you hit it right on, you know, the money. And notice that I don't know offense, but I don't think we have any providers here today, and yet they were all invited to come just to learn about it. And granted, it's always a time thing, and like you said, all of their focus is just managing the emergency room and, you know, that perspective. But there's so much more we can do out in the community, and that's why we have to get get it sold to them, but have them understand it too. And I think you're right on track with that. So I have to find out, were you able to, did you have to get a consult order from that, or could you just reach out for palliative care from the
No.
hospice in River Valley, or how did it?
Yeah, I think what the last that I was involved with it as an advocate for the patient, having quite a relationship with her in an outreach connection, just, you know, telephonically over the last year and a half. I since she's given me permission in the past to speak with her daughter, I just said, you know, I wasn't at this last meeting, I was away. I think this is the phone number for them. And Doc knows that we've had some discussions. You know, just call them and ask those nurses at Red River Hospice. You can go on their website, you can make your own referral, your own question, you know, tell them what the story is, and they'll take care of you and help you with the flow. And so that is what has occurred. Um, yeah, and it's in its process, you know what I mean? There hasn't been a return to home as of yet, but it is in its process. And they do have an advocate helping with palliative care, you know, the possibility of it happening.
And that's one significant difference, is anybody can contact palliative care. And even for, you know, because to enroll in hospice under the Medicare, you have to kind of, it's almost like you have to have a guru that knows all those techniques for doing that, because they do have to have a referral. They have to have, you know, do you meet this criteria? And there isn't criteria. This is like, do they decide to go see an eye specialist or an ear specialist? Now you're getting a palliative care specialist. And that's one of the ways, and one of the approaches that we sometimes will do, is we're here as an extra layer of support.
Yes.
You are a bridge. It's true, or at least it's a good analogy. When you're healthy, when the bridge is sound, you can handle anything. Cars, trucks, trains, all the bumps of life, no problem. You are set. But if you're facing a serious health issue, something like kidney disease, lung disease, or cancer, the bridge starts to falter, cracks appear, and pretty soon it's hard to withstand all that traffic that includes your own medical treatment. And that's where palliative care comes in. Palliative care is a specialized form of medical care, specifically designed for people with serious illnesses. Its main goal is to improve your quality of life by providing relief from the symptoms, pain, and stress that are an inevitable byproduct of both the disease and the medical intervention. In short, palliative care provides support for your bridge. And when a bridge is in trouble, there is nothing better. Now, palliative care, just like construction, is a team effort. It takes doctors, nurses, social workers, and other specialists, all working together with your physician to realize that extra layer, the layer that can make all the difference. It's a treatment method that makes sense at any stage of life and at any stage of an illness, because it's never too late to lessen the burden. So next time someone you care about is facing a serious illness, remember this bridge analogy and be sure to consider the enormous potential of palliative care.
Less than 2 minutes. And then the Get Palliative Cadet, it has a handout for patients and families. Boom, right there. And we worked, actually, that what we have on our website, we worked with the Center to Advance Palliative Care for this. But over here, I wanted to show you, over here in resources for clinicians, it talks about, is your patient, and here's some of the tools to see, is this person appropriate for it? And then 10 steps on what to say and do, additional resources. They have it for the media, for policymakers, et cetera. And when I was talking about getting on the map, if you go back to to the main screen, they have access provider directory. So I just want to show you, for the state of North Dakota, the entire state, just the hospitals alone, we only have a handful, okay, that are recognizing it. Our goal is for the home. So guess how many we're going to see in the home? Very few, you know, so that we're moving forward with this, but we have so much more to accomplish. That video, if you go to definition on it, it's right there too. So, and we have social workers and chaplains and nurses and everybody utilizing these tools to train our providers and our first responders or nurse practitioners, anybody that we can
It's never
find
gonna
to do
happen
that.
here.
You know, it's such an important thing, you know. I mean, just a 2-minute video, would they capture it a little bit more for your providers? Would that help at all with explaining it, or working with me, you know, setting up some time that I can just quickly go over what they can expect and how it's not taking away from them or whatever. That's what we want to do, is to reach out the awareness and education so that we can get that implementation and get on the map, you know, and have people know that there are ways that you can get out there. So. What do you think, Shel? Do you have any ideas for that moving forward?
You know, I think it's an opportunity. I think our administration right now is open to anything that assists provider engagement, you know, in relations with improvements and best practices. The one thing that becomes an issue is when, you know, do we do it over the noon hour? What audience do we have? But I do feel that as a critical access hospital, we're seeing a shift. You know, with COVID, you have more people caring for people at home with skilled needs versus people at home with a serious illness that just need collaboration and a voice. And with that palliative care, that's what that is. It just helps. So I think the fear with providers is like what you said, they're going to lose patients or they're going to lose the contact. Somebody's going to replace them. So, you know, I think it would help, Nancy, but I think you'd have to, what I would do first is have you visit with our CEO and the director of nursing maybe. And then, you know, I would think they would want first care to be on that site if somebody looks it up.
Exactly.
You know, because we want to offer everything.
Right. And the thing is the buy-in. I think you're right, you know, going to that administrative level and CEOs, because then providers will say, oh, I guess we do have to look into a little bit.
Right.
Not
right.
to do it from that perspective of being under any kind of policy or control, but sometimes that's what it does. And when we did our this last 3-year project, we reached out to several of our different critical access hospitals and the whole community and got them engaged in how to do that. So we did an asset. So one of the things we look at is our asset and gap analysis of that. You know, what things are we missing? What things can we fill in? And then having this references and things to support it, because we have a clinical practice guideline and it has, every section has specifics about rural. That was what they added to the newest edition of it, is how to make this work in rural practice, because it's such a different climate and stuff. So
yeah,
but yeah, definitely I'm available and others are too. That's why we're trying to do this network to make sure that we are able to reach out one-to-one.
Super. Well, thank you.
You're very welcome.
I'm pretty passionate about care in the home and overcoming those barriers.
And your example you gave, I'm sure everybody on today can relate to that, that we've all had similar, you know, and I love the stubborn, you know, is it Norwegian or German? Or it's North Dakotan. We have a lot of stubborn, but we also want our independence. We want our dignity. We want our respect, and we want to stay at home. You know, people want to stay at home. And some people have really liked telehealth because they're at home and in their own environment, and they can say what they want to say, versus where they're in another environment, they're going to feel a little bit different as well too. So you got a whole mix on all of that kind of stuff.
Right.
So
and with all the agencies working together to help with telecommunications and, you know, home monitoring systems and, you know, just every resource you can possibly think of to help people, you know, manage at home in their own way. You know, we got to meet people where they're at. And and I think, like, I had a call with Vision Rehab Services today, and you know, the whole thing is what she explained to me is federal grant dollars doesn't let them publicize things. So people aren't aware of all the things that can help them. Well,
Absolutely.
we just need to network more together and get it out there. I think care coordination and care managers in rural clinics has helped because it's given, you know, that psychosocial need to get implemented out into the clinical care and
Right.
and extend. But you know, it's still new. Even after 5-6 years, it's new.
Exactly. And,
So
and, and I, go ahead.
I should be done. There's probably someone else that needs to speak.
No, but it's a perfect prime example. You know, the very, very rural frontier areas, you know, why can't people be there, you know, for their health, especially facing any kind of serious illness, you know, with whatever's going
Yes.
on. And even earlier too, you know, from just even having advanced care planning conversations or finding out what are the resources available